record. Good afternoon. We'll continue our class on the uveitis. Now, we have already discussed the definition, clinical features, signs, symptoms, and the different clinical features. What are the findings will be there in different types of etiology has already been discussed in the last class. So now we'll be moving to the investigations and the management part of the uveitis. So I have mentioned that uveitis has several multiple etiologies. Based on the etiology, we have to do the particular investigation to identify the conditions, and the treatment will be according to the diagnosis. So we have to do the investigation based on either anatomical changes. So anatomical diagnosis will be based on the clinical characteristic. We have to assess what is the patient age, demographic, and onset of disease. Is there any past medical history or similar history of episodes of uveitis in the past? And full review of the systems considering known systemic disease association, if there are any, which I have already mentioned, can be presented with the uveitis. And differential diagnosis following history and clinical examination should be made, and based on that, the different investigations should be conducted to make the appropriate diagnosis, which is mandatory for the right treatment of the patient. So the anatomical diagnosis based on the clinical characteristics, patient age, demographics, onset of disease, is there any past medical history, review of any systemic disorder considering any systemic disease should be taken, and differential diagnosis following history and clinical examination should be done. Basic investigation which is to be performed in the most patients are the fasting blood sugar, sorry, that is not FBC, it is FBS. ESR, CRP, encephalitis, serology, chest X-ray to detect any hilar lymphadenopathy on lung infiltrates in case of suspected sarcoidosis. Other depends on the differential diagnosis. Example, if you are suspecting the TB, then we should do the MEN2 and chest X-ray, sarcoidosis, chest X-ray, serum calcium and serum ACE level. Ankylosing spondylitis, sacroiliitis X-ray joint, sacroiliitis joint X-ray, and other body parts X-ray as well as HLA-B27. We are suspecting VG, Wagner's granulomatous, then cytoplasmic antinuclear cytoplasmic antibody, chest X-ray, CT of the sinuses, and the renal parameters should be assessed. So this is the SUN working group anatomical classification of uveitis. So anterior uveitis means there is inflammation in the iris and ciliary or the ciliary body, that is involvement of the anterior chamber. Intermediate uveitis when there is involvement of the vitreous body, the pars planitis, posterior cyclitis or hyalitis. Posterior uveitis when there is affection of retina or choroid. The focal, it can be the chorioretinitis, retinochoroiditis, retinitis, neuroretinitis, focal multifocal diffuse choroiditis, and panuveitis when there is affection of all the three chambers or all the three parts, that is anterior, intermediate, and posterior uveitis, which are already mentioned in the first class. We will be discussing the appropriate investigation and the management according to that. So, as per the international guidelines, clinical classification of uveitis either can be autoimmune, infectious, or masquerade syndrome. So, in infectious, as all of us know, it can be either bacterial, viral, fungal, parasitic as Toxoplasma toxocara, and others. In the non-infectious, it can be multi-system disorders, so non-systemic association and no non-systemic association, and either neoplastic or non-neoplastic condition, which comes under the masquerade category, and the immunological category. Then, regardless of our choice of the laboratories, whatever we want to do, we should first go a thorough clinical examination and history as appropriate as we can for making the diagnosis, and based on that, we should select the laboratory test needed for confirmation. Many systemic manifestations may either can present it before the occurrence of uveitis or may follow the course of uveitis. So we should rule out all the possible systemic manifestations associated with uveitis whenever the patient presented to us. As in the Beckett's disease, ankylosing spondylitis, sarcoidosis, and all these systems. These are the disorders where the presentation of uveitis can be later, but sometimes the patient has uveitis and when there is no significant past history, and if do we suspect because of any other respiratory problem or any joint problem, we should first rule out the sacroiliitis, joint or ankylosing spondylitis, Richard syndrome. All these things should be ruled out if there is any particular problem. For example, if the patient already gives the history of respiratory symptoms with uveitis, we should make sure to rule out the TB and the sarcoidosis. So, in the anterior uveitis, I mentioned the presenting feature. Patient will give the complaint of congestion, pain, redness, and diminution of vision. And the redness in examination, there will be congestion. It can be diffuse congestion or circumcorneal congestion. You can see around the cornea, the diffuse congestion. This is the circumcorneal congestion, and this over the cornea is the entire diffuse corneal conjunctival congestion. So patient can have both circumcorneal or diffuse conjunctival, or both circumcorneal and the diffuse conjunctival congestion. You can see the other features also uveitis like irregularly dilating pupil or fixed dilating pupil. As these are the keratic precipitates which I have already mentioned, the different type of period keratic precipitates which will be present in the different types of conditions. Like granulomatous uveitis usually have mutton fat KPs, and non-granulomatous will have small to medium sized KPs. Healed uveitis, you will see the old non-acting, non-active KPs, and herpetic and heterochromic uveitis will be have. Distillate of fine KPs, which we have already seen in our previous class. So to make the diagnosis on the slit lamp examination, we should do the assessment of how much cells and how much flare is there, as I have mentioned according to standardized uveitis nomenclature committee. So this is the grading for the flare, which extends from 0 to +4. In the same way goes for the reaction. So in the reaction, you have to mention the cells, how much cells are there per high power field, and this is also again the standardized uveitis nomenclature grades. 0 to +4, 0 is nil, +0.5, plus is 1 to 5 cells, and there are 6 to 15 cells. It's +1, +2 when there are 16 to 25 cells, and 26 to 50 cells are the +3, and +4 when there are more than 50 cells. So the presence of these cells and flare gives us the diagnosis of the severity of the uveitis. How severe the uveitis irrespective of the etiology. Whatever etiology, based on that, how severe the reactions are, we have to do our management based on that. If we need only the topical, we need the topical and systemic, or do we need to manage the patient with some other medications like immunosuppressive or steroid sparing agents, whatever. And if any supplemental medications, like if the joint problems are there and any further management is needed, that all should be done after the classifying the uveitis pattern. So this is a picture which is showing the different types of nodules, which I have already mentioned. The iris nodules will be deposited. So when you see the slit lamp examination, observe thoroughly presence of iris nodules. And if you see, presence of these nodular lesions, these are the classical Uveitis nodules which are present on the pupillary margin. So I told based on the scientists who search them, usually the iris nodules are of two types. Either the Uveitis or the Busaka. Uveitis nodule, how you to remember? Just remember, Uveitis has two P. P means pupillary point. So pupillary margin, the nodules which are present at the pupillary margins are the Uveitis nodules. See, all are at the pupillary margin. And Busaka nodules, those which are present at the stroma or at the collarate level. Okay? Beyond the collarate, you can say. So just remember the nodules which are present at the pupillary margins are the Uveitis. The other one is the Busaka nodule. So These nodules gives you kind of a confirmative diagnosis. They can be there in few certain conditions also, but they are one of the pathognomic signs of the uveitis, anterior uveitis. So if they are there, then you can assess, and they also gives the indication towards the severity of the uveitis, because they are usually not present in the mild uveitis or up to moderate. They present in the chronic recurrent or long-standing uveitis, and based on that, we'll make the we'll confirm our diagnosis and we'll try to manage. And these nodules tend to occur over the time. This is another picture which show the formation of synergy at different levels. See, the first picture it shows the formation of the posterior synergy in the early stage or first attack in the beginning. The most of the pupillary area are intact, pupil is dilating. Still the synergies are present at place. Rest of the pupil is dilating. You can see the second picture where you can see the extensive peripheral signage. Pupil is not able to dilate. One fibrinous thick membrane also has formed in the pupillary area. And you can see the iris atrophy. The iris tissue has lost its normal architecture. So these things are present either in the recurrent uveitis or the severe uveitis, usually of chronic grade, where this the fibrinous membrane has been formed over the nucleus or lens. Coming to the lens, what the findings you will get in the lens? As I have already mentioned, the exudates or the whatever the oozing material comes out from the uveal tissues gets deposited at the various places. Same, it gets deposited at the cornea, iris, and it gets deposited on the lens also. And the patient, either the exudative material will get deposited over the anterior surface of lens, but sometimes it can go posteriorly and can got deposited over the subcapsular area and can lead to the development of posterior subcapsular cataract. And sometimes it can form the cyclitic membrane behind the posterior capsule also. And the management of that is different. So many patients with uveitis develop the cataract because the underlying inflammation, and another possible things is use of the corticosteroid. Because the corticosteroid is one of the mainstay of it's the mainstay of the treatment for the uveitis. We have to give that to the patient, and when the patient is using the recurrent for the long time, can develop the cataract. As I mentioned, the PSC or the posterior subcapsular cataract, which is one of the common cataracts seen. These cataracts derived, or they are divided in the category of complicated cataract. As I mentioned, their appearance, the polychromatic luster, breadcrumb appearance, they are commonly seen in the cataracts found after the uveitis attack. So they are the class of complicated cataract, and the patient has to be treated according to the diagnosis. We have to take certain precautions while we are managing these kind of cases in OTs. So we have to use that. Like already we know that patient has uveitis or old uveitic attack, the chances of reactions will be there. So it's better to operate the patient under the steroid and antibiotic cover, and give the long lasting or for the long duration steroid in post-operatively also, after making all the precaution, taking all the precautions, that patient doesn't have any contraindication to put him on the long-term steroid, because the patient has already received the topical, maybe the systemic steroid also before, and continue the management with that. And also, if there are so much synergy, like I have shown you just in the previous slides, this almost 360-degree extensive synergies are there. So they are the complicated cases to operate. While taking these cases, we should use, as I have already mentioned in the last class, we should use the different rings or pupil dilating agents. You can use the Metrican if possible, iris hooks, BSX rings, malagnin rings. All these rings are there to make the pupillary dilatation adequate, so that we can perform the cataract surgery much comfortably than the as the case. You can see how it's complicated. This is the posterior uveitis, or you can say the intermediate uveitis, where the vitreous has been affected, as in seen the toxocara and toxoplasma. You can see the vitreous get haze as the vitritis increases. So you can grade, you can see this zero grade, where you can see the entire vitreous, retina, disc, vessel, everything is mild vitritis, and very or slight blurring is there, but still you can see the details of disc, vessel, and map. This is grade one, when there is a haze where you can see the disc and vessels, but details not made out. And then the grade two reaction, where you can see the disc and large vessels, but the small vessels and the peripheral details or other details not seen. So the grade three, faintly visible disc, but none the other details seen. And grade four, very extensive vitritis. You can see nothing is seen. Only the glow is present. So these kind of things you can get in the toxocara, toxoplasma, or other vitreoretinitis condition. Herpes also, the different conditions. So these are the things which will affect in the patient vision and the patient condition. Based on these findings and assess the patient anterior segment, see the entire finding and do the management of that. We have to find out what can be the positive agent. We have to do the investigation based on the particular findings. For special findings, we have to do some additional tests also. Do that, find out the cause, and then manage the patient accordingly. Sometimes we are not able to make the adequate diagnosis in the absence of a lack of testing, and the patient does not get the proper treatment. So it's better to do the thorough examination and use all the appropriate tests which are possible to rule out the diagnosis and to do the management accordingly. So these are the findings with trust obesity. And intraocular pressure. I have already mentioned, usually I have mentioned, I had shown you the formation of seclusopuctea, occlusopuctea, how do they act, what they do cause, how do they lead to the iris bombay formation, and how do they lead to formation of peripheral anterior synechiae. So they block the both aqueous rotation from posterior chamber to anterior chamber and drainage of aqueous chambers. In the both ways, aqueous get collected in the anterior and posterior chamber and can lead to the increased ocular pressure. But sometimes it can, the uveitis can lead to the occurrence of low intraocular pressure also, which I have mentioned. When there is a severe affection of the ciliary body, there is a reduced secretion of the aqueous humor, and when the aqueous humor is not getting produced, it can lead to the occurrence of low intraocular pressure. Occasionally, the intraocular pressure may be elevated. The mechanism already have seen in case of severe ring synechiae or severe posterior synechiae formation, as in herpetic uveitis and Kushner-Schlossman syndrome. So now moving to the next thing. The thing is, we are discussing about the investigation, but we should know when to investigate and when to not investigate. Is there mandatory that we should do all the investigation in all the patients every time? No. We should know when to treat the patient. Better than that, first of that, before that, we should know when not to treat the patient. If the patient has present for the first time having mild to moderate level of uveitis, and preferably if it's a uniocular, then it's not mandatory the patient should be treated. Patient should be treated, but it's not mandatory to investigate with all the needed investigation. You should examine the patient thoroughly. All the anterior and posterior segment, all the examination should be done completely, but all the blood tests which we are going to discuss in the upcoming slides should need not to be performed in the first visit only. If the patient has the first episodes or have only mild to moderate uniocular or unilateral uveitis, the typical clinical features of uveitis, cells flare, congestions are there, no history of any systemic illness, not there. A systemic diagnosis compatible with the clinical features. One more thing, if you do the thorough examination with the clinical history and you can confirm your systemic diagnosis of uveitis, you can avoid the all other tests which are needed to confirm the different types of uveitis or to rule out different systemic disorders at the first visit. You can wait and ask the patient to have the medications and observe. If the patient doesn't get resolved, if the patient presents with the recurrent uveitis, then you can ask the patient to go for the all other medical checkups which are needed for making the diagnosis. Now, when we need to investigate the case of uveitis, if the patient presents with severe uveitis, you have to examine. If the patient presents with recurrent uveitis after management, this patient gives with the some other clinical history which indicates us to have that indicates us to that the patient might be having particular systemic illness, and the uveitis might be one of the associated features of that illness. Then in that case, we have to make sure we have to rule out that disorder if the patient presents with bilateral uveitis, if there any granulomatous signs are there, if, like if the patient has glaucoma or tuberculoma anywhere else in the body, patient has respiratory problem, joint problems, then, or if the patient already have with the associated intermediate or posterior uveitis. And one more thing, the routine syphilis serology should be done in the patient. HLA tissue typing, as I have already mentioned, we will discuss in the upcoming slides when to do the HLA-B27 testing. HLA-B27 is a surface one. It's present and it's an antigen which is present over the surface of the cells, that to T cells. And very strong association has been found of the HLA-B27 with the ankylosing spondylitis, Ritter syndrome, psoriatic arthritis, and arthritis in inflammatory bowel disorders. And in few conditions where even the patient doesn't have the association with rheumatoid arthritis, Ritter syndrome or ankylosing spondylitis or inflammatory bowel disease, also patient only can present with the uveitis. The other symptoms might present later, like vice versa. With these symptoms, patient might have the uveitis feature later. The other way also, if the patient is getting a uveitis feature, maybe the patient, you test the HLA-B27 if you suspect bilateral uveitis, and patient is positive, then patient might develop all other symptoms over the time. So, for diagnosing the syphilis, serology is mandatory. What are the tests you should do to diagnose the syphilis? ELISA, enzyme immunosorbent assay. It's a highly sensitive and specific, but it takes around 3 months for the results to come. So you can't wait, you can't keep the patient on hold for the treatment. The other non-specific is the RPR or VDRL or positive. The RPR is rapid plasma reagent antigen, or VDRL, renal disease research laboratory test. They are positive in the early infection. In the patient serum, in this test, patient serum, patient which is presented to you and want to test the serology for the syphilis, its serum should be mixed with commercially prepared carbon-like cardolipid antigen, and you should observe for the any clumping of antigenic particles. So you see, this is shown. You see, this is the RPR, rapid plasma reagent antigens are already placed, and the patient serology serum is a normal patient, no reaction. This serology, and you see this clumping. This is the patient is positive, so it shows the clumping of antigenic particle, usually after 4 to 5 minutes. And if you can do the fluorescent treponemin antibody, then you can see the movement of fluorescent treponemes. These are the treponema pallidum, which are the positive agents. They have the tendency to fluoresce. Toxoplasma. And I have mentioned Toxoplasma gondii, which is the primary host is. The primary host is the cat. Through the feces of cat or the food get infected with the feces of cat, it comes to the other creatures like human and all. So how to diagnose that? The one important test is 7-kilomet test. That is the dye test. In this test, the live organism uses which are exposed to the patient serum complement. The cell membrane of the organism are lysed in the presence of specific antitoxoplasmic IgG, and the consequence of organism fail to stand with methylene blue dot. And this test is still the gold standard. This test is the gold standard for the diagnosis of toxoplasmosis till today. in which the live organisms are used, and the live organisms, when they get react with the specific antitoxoplasma IgG, the lysis happened, and the result is what? Once the lysis happened, the organism does not take the methylene blue dye stain. It's usually when a methylene dye blue test is done, the organism take the stain. And when you mix them with the antitoxoplasma immunoglobulin, they get lysed and the stain gets negative. So it is still the gold standard test for the making toxoplasma diagnosis. The second most important test for this, the immunofluorescent antibody test, which utilizes the dead organism. So in the dead organism, they are exposed to the patient's serum and anti-human globulin, which are stained leveled with the fluorescent. The fluorescent leveled anti-human globulin or patient serum globulins are then mixed with the dead organism, and it result in a fluorescent microscope. Observe using a fluorescent microscope, and the fluorescence is seen. So two tests. First thing, the gold standard is the 7-filament or dye test. With methylene blue dye test is methylene blue dye is used. The gold standard where the patient serum organism utilized, which are the live organisms, are mixed with the antitoxoplasma IgG, and then staining becomes negative. The second one, where the dead organisms are mixed with the anti-human globulin antibodies, and then they are used under assist in the fluorescent microscope, and the fluorescence is seen. Third one is the heme agglutination test. Here, the whatever the lysed organisms are there, their coating is done over the red blood cells, and they are exposed to the patient serum. So patient serum means already the whatever the organism are there, the lysed or wall of that organism is coated over the RBCs and it mixes with the patient serum. So since the patient serum has the active toxoplasma, they will cause to agglutinate the RBCs. So basically, you are using the RBCs which are coated with the lysed organism and then mixed with the patient serum. The patient serum which has the live organism will lead to the lysis of or agglutination of the RBCs. So this is the heme agglutination test for the diagnosis of toxoplasma. So remember all the three tests. First is 7-filament test where the live organisms are used with antitoxoplasma anti-globulin antibody, and methylene dye blue test become negative. It's the gold standard. Second one, immunofluorescent antibody test where the dead organisms are mixed with anti-human globulin and assessed in the fluorescent microscope and shows the fluorescence. Third is heme test where the live organisms are coated on the RBCs, and then these RBCs are get mixed with the patient sera which are already having the toxoplasma in the active form, lead to the agglutination of RBCs. So these are the important tests to make the diagnosis of toxoplasmosis. And along with, once these tests are confirmed, you see what is the uveitis level, how severe is the uveitis, and with the toxoplasma management, you do the management of the uveitis, which we will discuss in the upcoming slides. And the ELISA, enzyme-linked immunosorbent assay test, involves binding of the patient's antibodies to an excess of solid phase antigen. Assessment of enzyme activity provides the measurement of specific antibody concentration in the patient's sera. This complex, once the patient's antibodies are mixed with sera or antibodies mixed with antigen, then this complex is then proceed for the ELISA. This first, its patient's antibodies are mixed with the antigen, and this complex is then exposed to enzyme-linked second antibody, and then we assess the enzyme activity, which provide the measurement of specific antibody concentration. Any positive titer, even in the undiluted serum, is significant. If the ELISA you perform and you get the any positive titer, even if the undiluted serum is significant in the presence of a fundus lesion. These tests can also be used to detect antibodies in the aqueous, which are most specific than those in the serum and useful in other conditions such as the cat scratch fever and toxoplasmosis. So ELISA is very specific test which assess the presence of enzyme activity or antigen antibody in the patient serum. So it can detect, and rather than patient blood, you can also use the patient aqueous. If you are having the uveitis along with any fundus lesions are there and you are suspecting, you can perform the ELISA on the aqueous humor also by the AC tap. And it is already written the slide, the AC ELISA of the interior chamber is more specific than those with the serum, and it is useful in other conditions also, like toxocara and toxoplasmosis. And if there is any positive titer with undilated serum, even in the undilated serum, is the significant for the fine confirmation of the diagnosis, and the management should be done according to that. Enzyme say there we will assess the serum ACE enzyme. It's a non-specific test which is usually most significant for the sarcoidosis, but it is also can be seen in the leprosis and TB reaction. It's mainly for the granulomatous reactions, but it's usually elevated in more than 80% patients of sarcoidosis. So it's quite significant in the sarcoidosis cases. As I have already mentioned, in the sarcoidosis patient, other than doing the systemic workup, you should also get it done the check the serum calcium and serum ACE level. If these both are elevated, despite with the uveitis, it's quite likely the patient will have the sarcoidosis. The normal range of this is 32 to plus minus 32 plus minus 8.5 international unit. In patient with suspected neurosarcoidosis, the AC levels can also be measured in the cerebrospinal fluid. AC may also be elevated under the TB lymphoma and asbestosis. That's why in the patient with non-pulmonary tuberculosis, if the patient has neurological illness, so the CSF analysis for AC done in that also. Elevated serum ACE marker or CSF ACE marker is important indicative of the TB infections to the brain. But when it comes, it can be the neurosarcoid also, other than neuro TB, so neurotuberculosis. So in that conditions, what we should do, we should assess the serum calcium level, and we should do whole body the X-ray, and then we should do how much the lungs involvement, the pattern of lungs involvement, and the involvement of joints are there or not. And based on that, we should make the diagnosis of the sarcoidosis. Lysozyme is the group of enzymes that is formed on the polymorphonuclear neutrophils and numerous secretion, including the tears. It's less sensitive but is specific than the serum ACE. It's considered then more specific than the serum ACE, especially in the sarcoid tuberculosis, because it causes lysis of the organism. Then as I have already mentioned, one of the common investigations which we should perform all the blood tests in the patient with uveitis, the ESR and CEVC, C-reactive proteins. They are the acute phase reactant and they are elevated in the systemic inflammatory diseases. So we should perform in all the uveitis cases whenever we are going for the lab test, and we can perform these tests in the first episode also. If we are not going for the other tests, that is, we can do these tests which will make out or which will help us to rule out if there is any inflammatory pathology is going on in the body or not. So these are the tests for the particular conditions which we have discussed till now. So these are the indications, different conditions, HLA typing way, ankylosing returns, and the psoriatic arthritis, inflammatory bowel disease, syphilis serology. Invariably, we should done first most important test, highly sensitive and specific ELISA. If not possible, RPR, VDR is early test to be done, and this is the trichonoma pallidum FTA antibodies test, how the trichonoma looks, and the serological test which shows the clumping of antigenic particles. The toxoplasma, most common test is Samin Killman test, which is the gold standard using live organism, and the immunofluorescent antibody test where the dead organisms are seen under fluorescent microscope, and hemogglutinescence test where the patient sera leads to the agglutination of the lysed organism coated RBCs. ELISA, most sensitive test where the antigen antibody complex is incubated for the enzyme and second antibody, and this test is highly specific and especially if we can do the aqueous tap and ELISA for the aqueous humor. It's quite specific and sensitive to make the diagnosis of other infectious disease also other than toxoplasma like toxoplasma, cat scratch fever. ELISA with any fundus lesion is significant in making the diagnosis even if it is in the undiluted serum. Serum ACE levels, as I mentioned, can be elevated in more granulomatous conditions, especially the TB, sarcoid, and leprosy. But it's quite significant. It's quite specific for the sarcoidosis in more than 75 to 80% cases. We can see this, and if the patient has hypercalcemia along with serum ACE elevated level, it's quite significant diagnosis for the serum uh, sarcoidosis. Serum ACE levels can also be found elevated in the patient with tuberculosis, especially the CSF. So whenever the CSF levels AC is high, usually we get the suspicion of tuberculosis and the sarcoidosis due to the other investigation like the serum calcium level and other joint X-rays and lungs X-ray, chest X-ray. So we can see the differentiating features of the TB and hilar lymphadenopathy and sarcoidosis or other joint involvement, skin involvement. If these features along with hypercalcemia are there more, they give the diagnosis of sarcoidosis and they differentiate it from the tuberculosis. As I mentioned, the normal serum level will be 32 plus minus 8.5. So if serum levels is more than that, we can suspect the above granulomatous conditions, which we have discussed just now. And based on the other investigations and the X-rays and other findings, we can differentiate these things in each other, and we can go with the management according to that. The lysozyme is not sensitive and less specific than ACE, but because it's a organ which is present over the polymer of neutrophils and several other secretions of the body like tears, saliva, and all. The ESR CRP, which can be the one of the prime tests, which is done in the cases of uveitis. Whenever we select the patient for the blood test, the first important few tests which are needed are the CBC, ESR, CRP, because the CBC, ESR, and CRP are the acute phase reactants, so they can be elevated in selective inflammatory disorders. So they give one indication towards the inflammatory pathology. Other tests, then ESR and CRP, which we will be doing. The CBC, usually the leukocytes will be raised in the infectious condition and we'll get the picture of leukocytosis. Anti-neutrophilic antibody, as I have already mentioned, the juvenile rheumatoid arthritis, juvenile idiopathic arthritis, JIA, which is one of the common cause of the uveitis in the children, but it is seronegative for the rheumatic factor, but positive for the ANA. ANCA, which is usually C-ANCA, which is seen in the venous granulomatous, it's anti-neutrophilic cytoplasmic antibody, I think cytoplasmic. Check it. Interferon gamma release is done usually for the 24 TB gold to assess the presence of TB, syphilis serology, and HIV serology. Skin test to measure the certain diagnosis. Tuberculin skin test, that is the MANTO, where the intradermal injection of purified protein derivative of Mycobacterium tuberculosis is taken and injected over the underlying the subcutaneous plane on the skin, and the results is read after 48 hours. So if there is a development of induration of more than 10 mm, 5 to 15 mm within 48 hours, this is positive result. Negative result usually excludes TB, but may also occur in patient with advanced consumptive disease, where the patient has developed the severe stage and the consumptive organism can detect that profile PPD. So the test can be negative. Weekly positive result does not necessarily distinguish between the previous exposure or previous active disease or BCG. Even with the patient, children, those who have received the BCG vaccination can also have the weekly positive test for the tuberculosis, that does not mean the patient is positive. But if the patient shows the test result weekly positive, doesn't it can be due to previous exposure or any previous active disease also. Strongly positive result. If the duration goes more than 15 m, usually indicative of active disease since the level of response is not expected after long exposure to the vaccine or in the mild diseases also. It's an active disease which is causing so much induration to occur after 48 hours, that is more than 15 m. Lepromin test, it is done, it's an intradermal test like the leprosy. It's done for the tuberculosis. So the lepromin to detect the lepra bacilli. Here also intradermal injection of an extract of leprosy bacilli is given, but it differs from the tuberculin test because it becomes positive after several weeks. And the another problem with this can be strongly positive in it's to detect the lepra bacilli, but it is more. It's always strongly positive in the tuberculoid leprosy rather than in the lepromatous leprosy where it is negative. So it's not like it is always positive in all the tests. It's positive in the tuberculoid leprosy, strongly, and negative in the lepromatous leprosy. It's also a bronchomatous intradermal test. Then coming to the other investigation like X-ray. So sacroiliac joint X-ray is important for the diagnosis of the sacroiliitis, and which is found in the ankylosing spondylitis. Checks X-ray to see sarcoidosis or tuberculosis. As in the sarcoidosis, we will get the hilar lymphadenopathy and the infiltrative lesions. In the same tuberculosis, you will get the congestive lesion and the infiltration of the lung tissue. Ocular imaging, like B scan, it's usually done when the either cecclusio pupillae or occlusio pupillae there is extensive synechiae or iris atrophy and fibrosis has occurred over the lens in the anterior segment, or the severe opaque media is there due to deposition of exudates over the corneal endothelium. We can't see the details of the posterior segment or even the anterior segment. In that condition, we can use the B scan ocular imaging to assess the condition. What is the status of the lens? What is the status of vitreous and the posterior segment? Fundus autofluorescence, it's suspected posterior segment pathology. We do the fundus autofluorescence such as mute syndrome, multiple evanescent white dot syndrome, where we can use the fundus autofluorescence to assess the condition and diagnose the disorders. Fluorescein angiography is useful in the following circumstances. If there are suspicion of the retinal vasculitis, to assess the retinal vasculitis conditions, we can use the fluorescein angiography. Diagnosis of any macular disease, particularly cystoid macular edema, or any CNVM or CNV if you are suspect. Demonstration of, in case of CMO, if there is any ischemic lesion or macular ischemia, other than if we suspect that macular ischemia is a cause of visual prognosis or visual loss rather than CMO, that macular ischemia can be diagnosed with the fluorescein angiography. Angiography, it's useful in differentiating between the inflammatory and ischemic causes of retinal neovascularization and specific uveitis that have characteristic feature like acute posterior multifocal placoid pigmented APMPPP, acute posterior placoid multifocal pigment epitheliopathy. This is the specific uveitis which are characteristic feature of NA and Hard's disease. They are the particular diseases where the fluorescein angiography is highly specific in making the diagnosis. They can't be diagnosed just on the bare examination. Endocyanine green angiography for evaluating the choroidal diseases, because the dye does not readily leak out from the choroidal vessels, which are better visualized through the RP. And ICG is able to detect the non-perfusion of choriocapillaries and provide first thing, whenever ICG is used, it is able to detect the non-perfusion of the choriocapillaries area, and it provides the information about the inflammation affecting the choroidal stroma. So the choroidal vasculature is better seen on the endocyanine green angiography. So to assess if there is any leak in the choroidal vessels or any choroidal non-perfusion area, the endocyanine green angiography is very helpful because it visualizes the choroidal vessels through the RP. Coming to the OCT, that is optical coherence tomography, which is useful in assessing the macular edema, level of edema, formation of is there any subretinal fluid collection, or is there is any epiretinal membrane formation, and it is also useful in delineating the like anatomical layer of inflammatory focus. And if suppose if the retinitis is there or macular edema or macular edema is there, at which level the inflammatory foci is resides and inflammation has occurred, that can be decided with the use of spectral domain OCT, and helps us in making the diagnosis and further management of the patient. Echo I have already mentioned that ELISA can be done using the echo and taking the echo humor for the ELISA test, which is more specific and sensitive for the like ocular toxoplasmosis or toxocara and cat scratch fever also. So the echo is done and sent for the PCR, and the echo can be sent for the PCR also if you want to do the testing for the viral genetic material, and it can be used for the culture, antibody assay, or microscopy also, ELISA also. Coming to the biopsy. So the biopsy of the tissues, like conjunctival biopsy or lacrimal gland biopsy, may be that useful in making the diagnosis of the sarcoidosis or other autoimmune disease when the patient has the symptomatic treatment. Means symptomatic clinical features are there in your suspected particular diagnosis, and the conjunctival and lacrimal gland biopsy also can be done. The vitreous biopsy, usually when suspected the intermediate uveitis, that is vitritis or endophthalmitis, vitreous biopsy can be done to rule out the infective organism or infective pathology which is there. Coming to the biopsies continuation, the retinal and choroidal biopsy. Till now, we have seen the biopsy of the conjunctival, lacrimal, and vitreous. Now, the retinal and choroidal biopsies are also useful in the particular conditions when the diagnosis are not established, when we are treating the patient for the long, but patient is not showing any response to the therapy. Further, after having the best treatment and there is a deterioration in the patient condition, or we want to exclude the malignancy or infection. So any condition where the patient is not responding to treatment or deteriorating after treatment or diagnosis is not established, or we want to exclude any malignancy or any infection, then retinal or choroid biopsies can be useful. Coming to the treatment, in short, if it's a first episode or the first case of uveitis or any uveitis, the topical corticosteroids are the prime treatment. It should be intense at first, and over the time it should be tapered to see how severe is the reaction based on either the plain topical steroid or with antibiotic combination. Usually the plain prednisolone 1% is preferred to give in the beginning with the intense hourly medications for the first 3 days or first 5 days, preferably for the first 3 days, and the taper according to that. Follow the patient consequently repeatedly for the IOP fluctuations or any other side effects. And after the steroids, see the pain condition, which is usually due to cyclospasm. So dilating drops or mediatic drops used to prevent the formation of posterior phalange and relieve the pain, which is cyclospasm. So cyclopentolate or atropine 1% in the TTS or homide, and the TDS frequency can be used, which will lead to the dilatation. So it will relieve the cyclophagic pain, cyclospasm, and also it will prevent the formation of synechiae both, because the people will keep on constricting and reacting, constricting and dilating and constricting, dilating and constricting. So it will help in making preventing the formation of synechiae. See the patient IOP. As I have mentioned, the development of occlusion cyclosis pupillary conditions can lead to the increased IOP. So if anything is persist that, then anti-glaucoma medications if started. And if needed, and the patient is fails to respond to the topical steroid, it's a very severe, then you can plan to give subconjunctival steroid injection of the Vidrigate. So this was the management for the anterior uveitis. Now coming to the management or treatment of the posterior uveitis. So same thing, posterior uveitis, corticosteroid is the main treatment for the inflammatory conditions, like it's anterior or posterior uveitis. But how to give the corticosteroid posteriorly? So either periocular injections, yeah, oral or intravenous IVMP, or if it is needed, can be given with other systemic immunosuppression. So intravenous methylprednisolone can be given in acute severe cases after consulting with the patient medical condition if there is if there is no contraindication to the patient for the IVMP. Then along with certain patients will have the certain other conditions which will affect the patient, or some other systemic conditions are there. So in those conditions, we can use the particular medications to treat those, like immunosuppressive agents which are needed to treat the other inflammatory or connective tissue disorder or the autoimmune disorder. So cyclosporin, tacrolimus, azathioprine, methotrexate should be used to as a steroid sparing agent also, or and sometimes as a steroid sparing agent, or for the immune suppressive agents. But whenever we are giving these medications, the side effects of these medications to be known, and the patient fitness or patient side effects should be monitored regularly. So what are the complications which can happen in the uveitis patients? As I have mentioned, the cataract, polychromatic luster, complicated cataract can develop. I have mentioned how the pupillae, the seclusive pupillae or occlusal pupillae get formed and can lead to the increased intraocular pressure and the permanent visual loss, and patient can go to the phases valvi when there is a optic neuropathy or there is a due to macular edema, chronic or long-term damage, permanent damage to the macula, or if there is a retinal disturbance. Coming to the few etiologies which I have already mentioned, like few interesting syndromes. Fuchs cyclitis, I mentioned it's an enigmatic disorder, and it's usually patient will have painless chronic unilateral uveitis in a young adult. Usually female patient will have heterochromia. Usually the patients will not have any synechial formation, so no intraocular pressure fluctuation, and patient will have usually a good prognosis with these conditions. Coming to the sarcoid uveitis, it's an idiopathic multisystem disorders. The clinical features, as I have mentioned, this is a multisystem disorder, so it will lead to the involvement of lungs, skin, and various other tissues. So skin, as I showed, the red painful tender lesions, the erythema nodosum will be there. The lungs, you will get the classical hyper lymphadenopathy, which is seen almost 80 to 90% cases. There is a severe pulmonary fibrosis with infiltrates can be there, along with joint involvement. And assessment of serum ACE and serum calcium, which I have mentioned, is quite important in making the diagnosis. So sarcoidosis, the sarcoid can lead to the affection of any segment or can lead to the pan-uveitis. And the management, which we have discussed, the topical steroids, and if needed, the immunosuppressant or the posterior, like oral or systemic steroids can be used for the management of these conditions. The Beckett's condition, it's presumed it's an autoimmune multisystem disorder. It's more common in the Mediterranean areas, and patient will present with the orogenital ulcers with the joint involvement. And in the eyes manifestations, patient will have the panuveitis, and should be managed with the aggressive immunosuppression with or without steroid. Usually without steroid, aggressive immunosuppression should be given, but the prognosis with the Beckett's is bad. As I have mentioned in case of Fuchs. Fuchs has a good prognosis, not much complications and good prognosis, but Beckett's has the poor prognosis. Coming to the sympathetic ophthalmia, which is usually occur in the normal eye after having any traumatic injury to the affected eye, and that can occur at any time from day 10 to the 6 months. So patient should be kept in the keep observation and should be managed as early as on urgent basis to avoid the possible complications of the disease in the other eye, and can manage with the steroids as well as immunosuppression. So the uveitis already we have discussed how the uveitis affect in children, the complications, and the possible conditions like toxopara goes to the human through the feces of the dogs. Usually it's affect the uniocular, but can lead to the uveitis, JIA, which is usually seronegative, affects the children in the early age, but positive for the ANA and having the poor prognosis in the toxoplasma and the intermediate uveitis. So the already discussed the toxoplasma chorioretinitis caused by toxoplasma gondii by eating the affected or infected cat feces. Usually the cat is the prime host and the humans are the secondary host. Can lead to the pan-uveitis with multiple focal chorioretinitis. Should be treated along with immunosuppressant and for topical and oral steroids. It should be treated with pyrimethamine with sulfadiazine, which is particular for the treatment of toxoplasma along with clindamycin. The picture already I have shown in the last class shows the vitritis with the presence of typical toxoplasma chorioretinitis lesion. So with this, we are reaching to the end of our uveitis class, and I have explained everything about the uvea, what is uveal tissue, where it is located, what are the parts of uvea, how does it get affected, what are the possible etiologies factors which can affect the uveal tissue, and which part is affected in which condition, and how to diagnose the condition. It's idiopathic, whatever, how to diagnose and how to manage. We have discussed in quite brief. Other than this, we need the particular treatment. For example, the syphilis serology to be done. If the syphilis positive comes, the patient should be treated. First of all, the patient should assess which level of the uveitis patient has. It has only anterior uveitis, anterior intermediate, or anterior intermediate and posterior, like pan uveitis is there. And then what is the drug of choice other than using the uveitic treatment like steroid and immunosuppression? If there is any particular treatment for that particular condition to be used, and we should follow the guidelines. If the patient is resistant or not able to tolerate that particular time, so which other medications can be used for that particular conditions. So with this, I think I have covered the most of the portions for you regarding the uveitis. So if any doubts are there, you can ask. Just in brief for a 2 minutes, just pictures and assessment of the uveitis. You know where's the uveal tissue located and what all the structures affected. This is the anterior uveitis. This is the post intermediate uveitis, the ciliary body and posterior ciliary body and vitreous, and this is the posterior. These are the uveitis. So definition is a type of anatomical locations. Etiology, normal aqueous which can handles. These are cratic precipitates. Different types of cratic precipitates. Cells and play, the gradings of the cells and play, you should remember. It's important for your exam point of view also. Both cells and play, you will be asked. The hypobion, how does it look? The findings of iris, these are nodules, which I have shown you. These are mucous nodules, Busaka's nodules, iris atrophy, neovascularization. Pupillary finding, you can see the festoon pupil, highly irregular pupil when there is ring synec formed. Occlusal pupil when ring synec is formed, and how does it lead to the enclosed ocular pressure? These are pictures of occlusal pupil. Now the occlusal pupil, how the occlusal pupil leads to the formation and affection of the eyes and lead to the increased ocular pressure. Findings of lens, this is the PSC, diagrammatic representation, the polychromatic luster, the cyclitic membrane in yellow you can see. Macular edema, papulitis, the phthisis bulbi, the common findings which should see the sign and symptoms. You should remember for the exam writing point of view. The iris pupils details, fundus details, the exudates in the posterior segment, and how the IUP decreased or increased, visual loss, what are these are the different etiological conditions, systemic conditions, or immunological conditions associated with uveitis. Children, what are the common causes? investigation, when to do, what to do, when not to do, all these things, the SVN classification, when you should do the investigation, you should know cells player. These are nodules, different types, Sinake, these are lens findings, which can have the cyclitic membrane, PSC, the reading for the vitruses, intraocular pressure fluctuation. These are the things which I mentioned when to investigations are indicated, when to not indicated. So when not indicated, when investigation is not to be done, is a condition, typical clinical feature or diagnosis, systemic diagnosis compatible with clinical features already confirmed. It's a single episodes of unilateral mild to moderate uveitis. So recurrent severe bilateral granulomatous associated with intermediate or posterior routine serology positive. Investigation indicated. What are the conditions associated with HLA B27, AS, Ritter syndrome, inflammatory bowel disease, syphilis serology, ELISA, RPR, trichonoma, how does it looks on FDA antibodies test, toxoplasma having failed when utilizes organism, it's a gold standard, then the immunofluorescent antibody utilizes dead organism, and immunoglobulination test, ELISA test, in which if the aqueous trap is done, it's quite more significance for the toxoplasma and scratch. Serum AC, which is more specific for the sarcoid, but can also be seen in TB and leprosy. Yes, CRP for the inflammatory disorders, other common conditions to be assessed. Skin test, tuberculin and leptomin, more than 15 positive for tuberculin strongly suggests a positive test. For active disease, the leptomin is strongly positive in tubercular leprosy, but negative in lepromycin leprosy. X-ray in the sacroiliitis. For sacroiliac and chest X-ray for TB and sarcoidosis, ocular imaging, B-scan, fundus imaging, fluorescein angiography, and endosymine vein angiography to see for the choriocapillaries, for leak, CNPs, optical coherence topography to assess the macular edema, level of edema, and if there is any subretinal fluid, aqueous biopsy for PCR for assessing the genetic material or culture sensitivity, on microscopy, biopsy of conjunctival lacrimal gland and sarcoid, vitreous biopsy for end-off, and retinal choroidal biopsy when there is no improvement with the treatment or deterioration or diagnosis not established or to exclude the malignancy. Typical treatment with corticosteroid and cyclophagy along with anti-glaucoma if needed, and subconjunctival injection, posterior uveitis with corticosteroid and immunosuppression. These are the complications. These are certain conditions which are present with the lesion. So with this, I am winding up the classes for the course. I'm completing my class. Thank you.